This presentation is about traumatic brain injury. First, let's start with the outline. First, we're going to have an introduction, talk about the epidemiology, then the definition of TBI, pathophysiology, clinical features, management, sequela, and reference. As an introduction, there is 60,000 TBI deaths annually. 44,000 occur at the scene or in the ER, and 16,000 occur afterwards. Traumatic brain injury is the leading cause of death and disability. Patients with severe head injury may frequently have other traumatic injuries to internal organs, lungs, limbs, or the spinal cord. Talking about the etiology of head injury, most of head injuries occur in falls, then in motor vehicle traffic, and then it could be struck by or against. There are other causes like assault, non-motor vehicle accident, and other transport. Suicide accounts for 1% of cases. The traumatic brain injury scale, the most commonly used scale, is a Glasgow-Coma scale. It can be done 30 minutes after head injury. Mild Glasgow-Coma scale is scored 13 to 15, moderate is 9 to 12, severe is less than 9. It's a dynamic scale. There are so many scales that are usually used, but the Glasgow-Coma scale is the most commonly used one. Talking now about the physiology, normal cerebral autoregulation. So the brain is a semi-solid organ that occupies 80% of the cranial vault. 20% of the body's oxygen supply goes to the brain, and 15% of the cardiac output. The cranial vault contains brain tissue, blood, and vessels, and CSF. One of the most important doctrines in brain physiology is the Monroe-Kelly doctrine. It defines the relationship between the volume of the three compartments. The expansion of one compartment must be accompanied by a compensatory reduction in the volume of the other compartments to maintain a stable intracranial pressure. So, CPP equal MAP minus ICP. So the cerebral perfusion pressure equals the mean arterial pressure minus the intracranial pressure. So, the cerebral autoregulation is a protective mechanism to maintain a tightly controlled environment where fluctuations in systemic arterial pressure or ICP do not have a large impact on cerebral blood flow. It's maintained by intact blood-brain barrier, a specialized set of endothelial cells with tight junctions. Disruption of the blood-brain barrier by traumatic injury may impair normal cerebral autoregulation. Now let's define primary injury. Head trauma is otherwise called traumatic brain injury. It occurs in two phases, primary and secondary. A primary injury results from the direct physical impact to the brain parenchyma, resulting in structural and shearing injury of neurons, injury to vessel, and interruption of neurochemical processes. It leads to hemorrhage, edema, and compression of intracranial structures. Secondary brain injury is characterized by a cascade of events that start within minutes of the primary injury and can last for hours to days. It exacerbates the brain injury and combines to worsen patient outcome. The injured brain has been shown to be intolerant of secondary insult than the uninjured brain. It's categorized into systemic insult and intracranial insult. Systemic insult, mainly hypoxia, PO2 less than 60, and O2 saturation less than 90. The mortality of TBI patients with hypoxia doubles from the normal TBI patients, and 40% of TBI ED patients exhibit hypoxia during the course. Hypertension is another systemic insult. Hypotension is another systemic insult too. It results usually from hemorrhagic shock, decreased cardiac output due to cardiac contusion or tamponade, or tension pneumothorax, which can happen with trauma. If we have hypotension, there is a decrease in cerebral perfusion, increase in cerebral ischemia, and it also doubles the mortality. Anemia can cause also secondary brain injury. Anemia can be defined here as in hemoglobin less than 10 or hematocrit less than 30. Hypo or hypercapnia can also enhance secondary brain injury. Other causes of secondary brain injury can be hyponatremia, hyperglycemia, hypoglycemia, hypoosmolality, acid-base disorders, fever, and hypothermia. Other systemic insult can include seizures, electrolyte abnormalities, coagulopathy, infection. Now let's talk about extra-axial fluid collections that can happen with traumatic brain injury. A very common one is epidural hematoma. It's usually caused by an injury to the middle meningeal artery. It happens with head injury and loss of consciousness. The patient has lucid interval followed by deterioration. This is the classic presentation in almost half the cases. It has a lenticular shape on CT. A second type of fluid collection is subdural hematoma. It's caused by injury to the bridging veins. Blood accumulates between the dura mater and the pia arachnoid mater. It increased risk in elderly and alcoholics due to decreased brain volume and cerebral atrophy. It's hyperdense crescent-shaped lesion. Intracerebral hemorrhage can be an intraparenchymal hemorrhage or a subarachnoid hemorrhage, which is a disruption of subarachnoid vessels. It's common in moderate to severe brain injury, and it carries a worse prognosis. It's twice as likely as other head-injured patients who suffer from death, persistent vegetative state, or severe disability. So what are the clinical features of traumatic brain injury? The hallmark symptoms are confusion and amnesia with or without loss of consciousness. Severe brain injury is often characterized by decreased mental status and presence of neurological deficits. Patients may also deteriorate from mild to severe head injury during the course of evaluation. Amnesia. Amnesia may be anterograde or retrograde, and duration does correlate with the severity and outcome of head injury. Loss of consciousness can result from rotational forces at the junction of the upper midbrain and thalamus that results in disruption of reticular neuron function and inability to maintain alertness. Now, let's talk about the Glasgow Coma Scale. It was developed by Teasdale and Janet in 1974. It was originally designed to measure 6 hours after injury to provide long-term prognostic information about mortality and disability. Now it's standardized to measure 30 minutes after the injury and repetitive measurement throughout the patient's stay in the ICU or on the floor. It should be performed after adequate resuscitation because the scale is sensitive to hypotension, hypoxia, intoxication, or pharmacologic interventions. So the scale can be there are 3 ways to score: the eye opening, the verbal response, and the motor response. The maximum score is 15 and the minimum score is 3. So the clinical features of mild head injury, the signs and symptoms are usually obviously milder. It goes from confusion, loss of consciousness, retrograde amnesia, vacant stare, inability to focus. Symptoms can be somatic, like headache, fatigue, dizziness, or affective, like irritability and sadness. The grading scale for mild head injury is 13 to 15 on the Glasgow Coma Scale. And any talking now about the clinical features of moderate head injury, the JCS is between 9 and 12. The clinical presentation varies widely. It happens in about 10% of the patients. It's a specialized subset, the talk and die syndrome. Basically, the patient is initially talkative and without significant sign of external injury and deteriorates within 48 hours. Epidural hematomas are seen in about 70 to 80% of moderate TBIs. Patients with talk and die syndrome who present with a JCS more than 9 but who deteriorate have been shown to have worse outcome than the patients who present with severe TBI at first. Severe head injury is a JCS less than 9, also occurs in 10% of patients with TBI. Early aggressive treatment is required with airway control, resuscitation, and admission to ICU. 25% of this patient population will require neurosurgical intervention. The outcome is usually poor and the mortality is as high as 60%. Typically, an abnormal exam, often evidence of external trauma, abnormal biliary exam, and neurological deficits. Some patients can present also with the Cushing triad, which is an acute entity seen in severely head-injured patients with significant increase in intracranial pressure and impending herniation. It results from ischemia to hypothalamus with poor perfusion to the brain, resulting in sympathetic stimulation of the heart to correct poor perfusion. The sympathetic stimulation results in hypertension, but the carotid baroreceptors respond with parasympathetic stimulation resulting in bradycardia. So basically, the Cushing triad is characterized by progressive hypertension, bradycardia, and irregular or impaired respiratory pattern. Now talking about the management of those patients in the ICU. Prior to their arrival to the ICU, the patients with severe TBI are usually received, resuscitated, and stabilized in the emergency department or the operating room. Once the severely head-injured patient has been transferred to the ICU, the management consists of the provision of high-quality general care and various strategies aimed at maintaining homeostasis, which include stabilization of the patient, prevention of intracranial hypertension, maintenance of adequate cerebral perfusion pressure, avoidance of systemic secondary brain insult, and optimization of cerebral hemodynamic and oxygenation. Now talking about the general monitoring. Every one of those patients should get an ECG, an arterial oxygen saturation monitor, capnography, arterial blood pressure, invasive arterial catheter can be used, systemic temperature should be monitored, as well as urine output, ABGs, and serum electrolytes. In the case of intracranial pressure monitoring, it can be done with non-invasive ICP monitoring and invasive ICP monitoring. Non-invasive ICP monitoring occurs mainly with clinical signs. The patient should be evaluated for the following: headache, nausea, and vomiting, especially early morning or if the vomiting is projectile. The degree of alertness and consciousness should be evaluated with the Glasgow Coma Score. Language comprehension, repetition, fluency, and articulation. Pupillary reactivity also should be examined. Other signs of increase in intracranial pressure should be change in extraocular movement and visual fields, change in vital signs, note particularly the absence of presence of Cushing triad, which are again respiratory depression, hypertension, and bradycardia, and sometimes the optic nerve sheath diameter can be evaluated, but that's very detailed and is usually not done. For imaging, non-contrast CT scanning of the head is a fast, cost-effective method to evaluate for elevated ICP and associated pathology. Findings that are suggestive of increased ICP are intracranial blood, bony fractures, mass lesions, obstructive hydrocephalus, cerebral edema, and midline shift. Invasive ICP monitoring can be used as a device that is placed inside the head, which senses the pressure inside the skull and sends its measurements to a recording device. The normal range is between 3 and 15 mm of mercury. Indication for invasive monitoring are in patients with JCS less than 8 after reversal of sedatives that were used during intubation, patient with risk of raised ICP under general anesthesia, unilateral or bilateral motor posturing, and closed head injury. The main benefit of an EVD is that it allows for therapeutic relief of elevated ICP via CSF drainage. The disadvantages are parenchymal hematoma or infection, obstruction of the drain that requires replacement, and the continuous monitoring requires nursing staff that is educated in management of an EVD. Talking now about electrophysiological monitoring, EEG is clinically useful to monitor the depth of coma, detecting non-convulsive seizures, or seizures activity in pharmacologically paralyzed patient. It's also very useful in diagnostic brain death. For analgesia, sedation, and paralysis in the ICU, to take care of those TBI patients, In severe TBI patients, endotracheal intubation, mechanical ventilation, trauma, surgical interventions, nursing care, and ICU procedures are potential causes of pain. Narcotics, as morphine, fentanyl, and even sometimes remifentanil, should be considered as first-line therapy, since they provide analgesia, mild sedation, and depression of airway reflexes, which is required in intubated and mechanically ventilated patients. Um, the narcotics can be obviously given as continuous infusion or as boluses. Propofol is the hypnotic of choice in those patients. Also, it's easily titratable and rapidly reversible once discontinued. However, propofol should be avoided in hypotensive and hypovolemic patients because it has deleterious hemodynamic effects. For mechanical ventilations, patients with severe TBI are usually intubated and mechanically ventilated. Hypoxia should be avoided. Prophylactic hyperventilation to PaCO2 25 mg of mercury is not recommended. Within the first 24 hours following severe TBI, hyperventilation should be avoided as it can further compromise an already critically reduced cerebral perfusion. Excessive and prolonged hyperventilation results in cerebral vasoconstriction and ischemia. Thus, hyperventilation is recommended only as a temporal measure to reduce elevated ICP. A brief period of hyperventilation to PaCO2 of 30 to 35 is recommended to treat acute neurological deterioration. Longer periods of hyperventilation might be required for intracranial hypertension refractory to all treatments, including sedation, paralytic, CSF drainage, and hypertonic saline. Talking about hemodynamic support, hemodynamic instability is common in patients with TBI. Hypotension is a frequent and detrimental secondary systemic brain insult, and it has been reported to occur in up to 73% during intensive care. Appropriately aggressive fluid administration to achieve adequate intravascular volume is the first step in resuscitating a patient with hypotension following TBI. In patients who responded poorly to adequate volume expansion and vasopressors, demonstrate hemodynamically instability, or have underlying cardiovascular disease, a pulmonary artery catheter hemodynamic monitoring may be considered. In the ICU, dextrose-containing IV fluids are to be avoided. The injured brain tends to absorb free water disproportionately from hypotonic solutions. Thus, isotonic solutions like normal saline or even lactate ringers are the fluid of choice for fluid resuscitation or volume replacement. Anemia is a common secondary systemic brain insult and should be avoided, with a targeted hemoglobin of more than 10 and hematocrit more than 30. Coagulation abnormalities should be aggressively corrected with blood products as appropriate. Hypertension is also a secondary systemic brain insult that can aggravate vasogenic brain edema and intracranial hypertension. However, hypertension may be a physiological response to a reduced cerebral perfusion. Hypertension should not be treated unless a cause has been included or treated, and systolic blood pressure of more than 180 to 200 or MAP more than 110 to 120. Normothermia. An increase in body and brain temperature is associated with increase in cerebral blood flow, cerebral metabolic oxygen requirement, and oxygen utilization, resulting in increased ICP and further potential brain ischemia. Therefore, avoidance of hyperthermia should be one of the mainstays of head injury management. It may require the use of pharmacological antipyretics and surface cooling. In the ICU, cerebral perfusion pressure should be monitored and considered very importantly. Cerebral ischemia is considered the single most important secondary event affecting outcome following severe TBI. CPP, which is defined as MAP minus ICP below 50, should be avoided. A low CPP may jeopardize region of the brain with pre-existing ischemia, and an enhancement of CPP may help to avoid cerebral ischemia. The cerebral perfusion pressure should be maintained at a minimum of 60 mg mercury in the absence of cerebral ischemia, and at a minimum of 70 mm mercury in the presence of cerebral ischemia. Mannitol administration is a very effective method to decrease ICP after severe TBI. Mannitol creates a temporary osmotic gradient and increases the serum osmolarity to 310 to 320 milliosmoles per kilo of water. The effective dose is 0.25 to 1 gram per kilo, administered intravenously over a period of 15 to 20 minutes. The regular administration of mannitol may lead to intravascular dehydration, hypotension, prerenal azotemia, and hyperkalemia. Mannitol is contraindicated in patients with TBI and renal failure because of the risk of pulmonary edema and heart failure. Hypertonic saline can also be given as an alternative to mannitol. In the ICU, it's very important to have a seizure prophylaxis for those patients. Post-traumatic seizures are classified as early occurring within 7 days of injury or late occurring after 7 days following injury. Prophylactic therapy, phenytoin, carbamazepine, or phenobarbital, is not recommended for preventing late post-traumatic seizures. Phenytoin is the recommended drug for the prophylaxis of early post-traumatic seizure. A loading dose of 15 to 20 milligrams per kilo, administered intravenously over 30 minutes, followed by 100 milligram IV every 8 hours, titrated to plasma level for 7 days is recommended. Patients receiving anti-seizure prophylaxis should be monitored for potential side effects. Severe TBI patients are also at very significant high risk of developing venous thromboembolic events, including deep vein thrombosis and pulmonary embolism. Mechanical thromboprophylaxis, including graduated compression stockings and sequential compression devices, are recommended unless their use is prevented by lower extremity injuries. The use of such devices should be continued until the patients are ambulatory. In the absence of contraindication, low molecular weight heparin or low dose unfractional heparin should be used in combination with mechanical prophylaxis. Nutritional support should also be given to patients with severe TBI. They are usually hypermetabolic, hypercatabolic, and have a hyperglycemic state with altered gastrointestinal functions. There is evidence suggesting that malnutrition increases mortality in TBI patients. Early enteral feeding is recommended than parenteral in patients with severe TBI as it's safe, cheap, cost-effective, and physiologic. The potential advantages of enteral feeding include stimulation of all GI tract functions, preservation of the immunological gut barrier function and intestinal mucosal integrity, and reduction of infections and septic complications. Other general intensive care interventions can be done to improve outcomes, like raising the head of the bed to 15 to 30 degrees, keeping the head and the neck of the patient in neutral position, to improve cerebral venous drainage and to reduce the ICP, and also avoiding compression of internal and external jugular veins with tight cervical collar or tight tape fixation of the endotracheal tube that would impede cerebral venous drainage and result in increase in the ICP. Turning the patient regularly to prevent pressure ulcers should be done. Eye care, mouth care, and skin hygiene should be provided. PTOT should be performed. Other symptoms can occur like affective symptoms, amnesia, neurological deficit like paraparesis or paraplegia, and sometimes the patient can have a persistent vegetative state. As a conclusion, TBI is a devastating injury, and often these patients would require monitoring and treatment in an intensive care unit. It is best prevented, so effort should be focused on preventing it. Time is precious, so early intervention is the rule, especially to reduce secondary brain injury to the minimum. Management of TBI patients requires multidisciplinary approach, frequent close monitoring, and judicious use of multiple treatments to lessen secondary brain injury and improve outcomes.